Hello, my name is Dr. Sanjay Dadamani, a heart failure specialist at Geisinger. I'd like to spend a few minutes discussing best practices and treatment of heart failure with you. Heart failure is a serious chronic condition that is considered a syndrome since a reduction in the cardiac output results in many changes at a neurohormonal level as well as with other organs due to decreased perfusion. The loss of pumping function of the heart can occur either because of reduced function, systolic heart failure, or stiff heart function, diastolic heart failure, also known as heart failure preserved ejection fraction or reduced ejection fraction. It is one of the most common reasons for visits to the emergency department and hospital admissions. There are several signs and symptoms that, if recognized early, can be effectively managed in the primary care office or heart failure clinic. Treatment consists of life-saving medications to treat heart failure, lifestyle modifications like weight optimization, fluid restriction, and sodium intake management, as well as increasing mobility, especially enrolling into cardiac rehab for systolic heart failure. That is a covered benefit with improvement in mortality. Additionally, underlying causes should be corrected, like ischemia or valvular heart disease, tachyarrhythmias, metabolic diseases like thyroid and diabetes, or even sleep apnea, for example. Despite our best efforts and care, people frequently develop exacerbations and need immediate attention, which should be facilitated in the office before considering the emergency department. Signs and symptoms include shortness of breath, especially with exertion, or with laying down, known as orthopnea, or nocturnally, paroxysmal nocturnal dyspnea. Worsening fluid accumulation, cough, and even if severe, hypoxia can ensue. All patients with heart failure should be cared for within a team environment so that they have access to the best available resources, including a case manager who can help with their education, lifestyle modification, and recognition of early warning symptoms to watch for that require urgent medical attention. Medical therapy for heart failure involves diuretic therapy as well as neurohormonal antagonists. Diuretic therapy, such as oral furosemide, is a loop diuretic, usually initiated at 40 milligrams a day or twice daily. This dose can be increased to 80 milligrams twice a day, but thereafter, the drug starts to become a little less effective and a switch to a more potent loop diuretic, such as torsemide or bumetanide, may be required. Additionally, for patients with heart failure reduced ejection fraction, initiation of ACE inhibitor therapy or angiotensin receptor blocker therapy may be indicated. For patients who fail to improve or who have persistent symptoms at 90 days or sooner, could be introduced with Entresto, which is an angiotensin receptor neprilysin inhibitor medication. Additionally, for severe symptoms, digoxin can be added, but will need drug monitoring as levels less than 1.1 are associated with fewer toxicities. Usually, the ACE inhibitors are not further titrated to allow for introduction of evidence-based beta blocker therapy for systolic heart failure. These beta blockers, namely carvedilol, metoprolol succinate, or bisoprolol, are titrated since maximally tolerated doses are usually associated with the best results and best outcomes. For acute exacerbations, oral diuretic therapy can be escalated and is often required and may be given intravenously if needed. Our diuretic titration protocol includes doubling of the baseline dose for 3 days along with monitoring of renal function and potassium. For severe symptoms or when patients already are on high-dose loop diuretics, metolazone either at 2.5 milligrams or 5 milligrams may be added, but used 2 to 3 times a week during an acute episode. Close monitoring of weight, renal function, and potassium are very important. Close communication between the cardiology or heart failure team is extremely helpful, especially when left ventricular ejection fraction is less than 25% or when patients have refractory class 3 or 4 symptoms. Device therapy is a well-known treatment arm for patients with systolic heart failure, usually ejection fraction less than 35%, and can be life-saving to decrease the risks of fatal ventricular arrhythmias. Additionally, for patients with left bundle branch block, CRT or biventricular pacing is a therapeutic option that can improve symptoms and survival. Patients who frequently have exacerbations, often who have progressive symptoms may have these symptoms for several weeks before seeking medical attention. I can't emphasize enough how important close surveillance, offering same-day access, and providing the necessary education to patients and their families to avoid their excessive and often unnecessary burden of ED visits or hospitalizations are. We owe it to our patients to keep them healthier and manage their diseases more effectively. Just a reminder about echocardiography. The initial diagnosis of heart failure is supported by the use of a 2D echocardiogram to diagnose systolic versus diastolic heart failure as well as valvular heart disease. An echo can be repeated at 90 days to reassess ventricular function before seeking device therapy or addition of medications. If you have any questions about a heart failure patient or would just like further knowledge or education, please don't hesitate to contact the heart failure team at Geisinger. Thanks so much for your attention.